Oh, it is recording. Okay. Did you get a little acknowledge that you're recording thing, or did it just start recording without letting you know?
No, I got the notification.
Oh, good. Okay. That's good. So let's talk. What questions do you have for me?
Gosh, I don't even know really. I was just kind of interested to hear any guidance that you're offering on
Okay.
how on how you would approach
Well, why don't we go
this.
through the focus points? Because I basically took that from the final.
Okay.
And so obviously I can't give you the questions, but I can make sure that you have, oh, there's a spelling mistake. I can make sure that you have all of the vocabulary. So when a question comes up, you know definitions, because a lot of times if you know the definition, you're halfway there.
Okay. That makes
And, so we can go through some of these things to see, if you're kind of clear
oh god.
on what each of these are.
Okay.
Okay.
All right.
So the vocabulary, so akathisia, I think one of the things that confuses a lot of people is
Mm-hmm.
whether or not akathisia is considered Parkinsonian.
Okay.
And
Um,
and so a lot of times that's one of the things that can mess with folks. And it is a side effect of the antipsychotics. Um,
yes.
Often it's actually more common than some of the others. And the reason for it um, can happen. It actually happens with a lot of different drugs. Akathisia can happen with the antidepressants, calcium channel blockade, some of the antiemetics, usually like Reglan, which is Reglan and Phenergan were both started as Parkinsonian kind of drugs.
Uh-huh,
So
yes.
they can cause akathisia. And so the cause they are pretty sure is because of the blockade of dopamine receptors. And what it results in is what patients describe to me as a deep restlessness.
Mm-hmm.
So it's like a restlessness that's internal, not brain. So it's the muscles, they say, just itching to get up and get moving.
So would
And
it be
so
like similar to like almost like a restless leg kind of
it
feeling?
is actually, it is very similar. The cause, of course, is different, but very similar in terms of movement and this sensation of restlessness that is impossible to ignore, is what I
Yeah.
usually hear from people.
Okay.
And it is dopamine related. Um, and it's not actually considered typically a Parkinsonian symptom. It's
Mm-hmm.
considered to be different than like the extrapyramidal symptoms. And so is considered something separate from um, like EPS.
Mm-hmm.
So the
And so,
Parkinsonian symptoms, when we think about Parkinsonian,
yeah.
let's see.
Can you just quickly what like so how does it differ from like tardive dyskinesia?
So um, so they're similar causes, right? It's
Yeah.
about that blockade of dopamine,
Uh-huh.
which in Parkinson's disease, the imbalance between dopamine and acetylcholine, where acetylcholine has the predominance, causes the bradykinesia, it causes that shuffling movement, the muscle stiffness, and that kind of
Mm-hmm.
business. So when you
Mm-hmm.
think about Parkinsonian symptoms,
Uh,
you think about extrapyramidal symptoms. Now, tardive dyskinesia is specifically muscle movement in the face is the
yeah.
predominant, right? So tardive dyskinesia, and let me show you, sometimes it's better if you can see a video.
Okay.
because it's something that if you've never seen it before, it's really hard to kind of imagine. It seems like something that is more abstract. So let me see if I can find a video. So hang on, let me share my screen with you so you can see that.
You know what's so silly is I didn't even realize I could see you.
Oh,
Okay.
all right. So do you see the video?
Yes, I do.
Okay.
Okay. Yeah, I've
That's
seen.
tardive dyskinesia classic.
Okay.
Okay. And
Mm-hmm.
so tardive dyskinesia is all about facial movements that they have zero control over. Often tardive dyskinesia, unless we catch it really early, is irreversible.
Yeah.
And so the first sign or suspicion, yeah. So these are classic tardive dyskinesia. And
Mm-hmm.
then when you think about extrapyramidal, oh, oh, election season, I'm so sorry.
It's okay.
Okay. Mhm. Classic. They'll have that Parkinsonian shuffle because their muscles don't move. They're not as flexible.
Mm-hmm.
Mhm. I've actually had patients do that. Mhm. Mhm. Yeah, you get these patients and I'll get these patients in my office and when you hear like the term blunted affect, um, a lot of times they don't show a lot of emotion, and it's because of the lack of muscle movement. It's not because they don't feel the emotions, it's because that lack of dopaminergic function causes their muscles to be stiff, including the ones in their face. And so, sometimes looking at the videos of this, some of this stuff is really good because, for instance, I was in critical care for 23 years before I started in psych. So some of these things, akathisia, I'd seen Parkinsonian symptoms, but from
Mm-hmm.
Parkinson's disease, right? So some of these things, when I was in school, I looked up videos because I had never seen them before. And that Ames video we just looked at a minute ago is actually a really good one for that. So,
Cool.
so the different degrees of agonism, right? So, an agonist, a full agonist, is something that stimulates the receptor to do what it's supposed to do.
Mm-hmm.
So, for instance, when we talk about beta 1 and beta 2 from like med surg, right?
Mm-hmm.
Beta 1 and beta 2 are heart and lungs, and their sympathetic nervous system. So, for instance, epinephrine stimulates beta 1, which increases the heart rate. That's a full agonist of beta 1.
Mm-hmm.
Beta 2 in the lungs, if you stimulate beta 2, it opens up the airways. So when we give something, for instance, like albuterol, that
Yeah.
is an antagonist at beta 2. So it's a chemical or a substance, whether it's a neurotransmitter or medication, that blocks the effect of that receptor.
Yeah.
An inverse agonist makes the receptor do the opposite of what it would normally do.
Okay.
A partial agonists are really important nowadays, especially in the treatment of schizophrenia. So a lot of the antipsychotics, the newer antipsychotics, are partial agonist. And the research says that these drugs, an example would be cariprazine, which is Vraylar, or Latuda, which is
Mhm.
lurasidone. So these are partial agonists of the D2 receptors. Okay. So
Okay.
what that means is in areas of the brain where there isn't enough dopaminergic function, the medication increases dopaminergic activity.
Mm-hmm.
An area of the brain where there's too much dopamine, the partial agonist decreases dopaminergic activities. So what that means is where you've got somebody who's got positive symptoms like hallucinations and what have you, that medication is going to reduce the positive symptoms. And by increasing dopamine where there's less of it, you're going to see a reduction in negative symptoms.
Yeah.
So that's the partial agonist. And there's a lot of the meds that we're using nowadays are partial agonists at D2.
Okay.
Does that make sense?
It does. It does.
Okay. Any questions about the agonist spectrum?
Um, I don't think so.
Okay. So if I were to ask you, for instance, if I gave a drug that was an inverse agonist of
Mm-hmm.
GABA receptors, what would that look like? What would that produce in terms of symptoms?
Say that one more time.
So if I gave something that was an inverse agonist
Uh-huh.
of a GABA receptor, remember GABA is one of our inhibitory chemicals. It's that calming chemical in the brain, right?
Mm-hmm.
So the GABA receptors respond, they're agonized by GABA. So if I gave something that was an inverse agonist, what would the result be?
It would reduce the amount of GABA, right?
It would reduce GABAergic function. And since GABAergic function, an example of an agonist of GABA receptors is Xanax.
Mm-hmm. Okay.
So if I gave something that did the opposite in those GABA receptors, it was an inverse agonist, what do you
Uh-huh.
think the result would be?
It was act opposite of
It would
something
act
like,
opposite. So if
yeah.
an agonist of GABA causes less anxiety, an
It would.
inverse agonist of GABA would increase anxiety. It would be
Okay.
anxiogenic.
Okay.
Does that make sense?
That does make sense.
Okay. First pass metabolism. First pass metabolism is something where when you take something orally through the gut, the liver metabolizes it very strongly. So in order to get past first pass metabolism, drugs that go through first pass metabolism have to be given at a higher dose than what the theoretical dose would have been.
Mm-hmm.
Okay. And so that's that. So anything that is, it has a first pass metabolism doesn't happen if it doesn't go through the gut, for one.
Mm-hmm.
And for two, what it means is the dose under research was so heavily metabolized by the liver that they had to use a much higher dose to achieve effect because so much of it is washed out by the liver. Does that make sense?
Yes.
So hyperprolactinemia is caused by there's the part of the hypothalamus, the tubero. Ooh, what was that word? Ooh, I lost that word. Let's see. So hyperprolactinemia is the result of too much prolactin being produced at the pituitary because dopamine regulates prolactin levels.
Yes.
Okay. And so when we block D2 receptors strongly, we can end up with a problem with too much prolactin in the bloodstream, resulting in somebody producing milk who probably shouldn't.
Yeah.
And so dopamine actually regulates that process.
Okay.
Yeah. And if you look at, I think that was in the module intro, the key points for that was module
I remember that. It was in the
schizophrenia
yeah.
one, module 3, I think. See if I can find it. So, because I can't remember the tubero. It frustrates me when I can't find my words. Getting old is not for weenies. I'm just going to say that.
Oh. I hear my patients say that all the time.
Yeah. Yeah. That plus the PhD, I think, ate some of my brain cells. Let's see, that's electron transmission. Da-da-da. Decision making module after that. There it is. Here we go.
Pop facile.
Tuberohypophyseal.
Oh,
It's the hypothalamus.
okay.
And so when there is not enough dopamine, that means that it inhibits the release of prolactin. So when there's not enough dopamine, prolactin is released too much. And so that's one of the side effects potentially of some of the, and usually the older, the first generation antipsychotics are more likely to do that than the others.
Mm-hmm.
Tyrosine kinase. Tyrosine kinase is one of the metabolites in the serotonin chain. So it is one of the enzymes that is activated and induces things like it works on a lot of things like insulin. It's responsible for some of the ATP production, but tyrosine kinase in mental health, we would look at, we're actually looking at tyrosine kinase inhibitors as a potential target for antidepressants. So these would be like third generation antidepressants, along with the CRF, the corticotropin releasing factor, is another one that's a potential target for third generation antidepressants.
Okay.
Synaptic plasticity,
Mm-hmm.
that has to do a lot with BDNF. So brain-derived neurotrophic factor. Used to be, when I was young, we told kids that once you killed your brain cells, it was done. They were over. So if you drank a lot, you were going to not be able to function as an adult. We now know that brain-derived neurotrophic factor is a chemical that actually helps to produce new neurons. And that's really important in a lot of different things. For instance, did you ever hear Gabby Giffords, who was a congressperson who was
Oh
shot
yeah.
in Arizona?
Yeah.
The idea of neuroplasticity, synaptic plasticity, actually saved the function that she has. Because what happens in the brain is if you've got an area that is not functioning normally,
Mhm.
brain-derived neurotrophic factor will build new synapses to try and accommodate for that loss.
Mhm.
Um, there are people who are walking around genetically less able to produce BDNF. So when I do like Genemind testing on my patients,
Uh-huh.
one of the things we look at is BDNF. For patients who don't make enough of their own BDNF, oddly, exercise actually is a drug for them
That's so interesting.
because it increases their BDNF. Sad thing is, their BDNF is so low, they're so depressed, they don't want to do anything.
Yeah.
So getting
Yeah.
them to get up and get moving is difficult. But synaptic plasticity is where the brain actually produces new neurons in light of damage or reduced function. And that's how we're able to accommodate things like strokes. When they don't recover, the
Mhm.
brain will produce new neurons in other areas of the brain to try and compensate.
Mhm.
The monoamine hypothesis is the one that says that chemicals like serotonin, norepinephrine, dopamine are responsible for things like depression. And the proof for the monoamine hypothesis is pretty much only that those drugs tend to work for depression.
Mhm.
But they're considering it something that kind of falls short on a number of levels, right? Because it doesn't explain everything. And there are other things like the tyrosine kinase and the corticotropin releasing factor. These are all things that also have an effect, as well as genetics and epigenetics. And so
Mhm.
the monoamine hypothesis is all about like serotonin, norepinephrine, dopamine, and their effect on mood. Okay.
Mhm.
The term parasympatholytic, of course, lytic means breaking it. So
Yes.
anything that's parasympatholytic will cause something that looks like a stress response, a sympathetic response. So
Mhm.
increased heart rate, increased respiratory rate, increased alertness in the brain, decreased GI function.
Okay.
Okay. Um, nociceptors. Let's do epigenetics first because it's one of my absolute favorites.
Sure.
Epigenetics is the study of things outside of the body that affect DNA. So, for
Mhm.
instance, I wrote a paper some years ago about Native Americans and diabetes because they
Mhm.
have tremendously high rates of diabetes, alcohol abuse, and other cardiometabolic issues.
Mhm.
It turns out the research is increasingly showing that those people are suffering from things like the Trail of Tears generations later. So, epigenetic changes are responsible for things like historical trauma that we see played out in people's DNA, but it's also things that happen, for instance, in childhood.
Mhm.
So, when somebody is abused as a child, it
Mhm.
literally changes their DNA. As well as pathways in their brain, right? So those are examples of epigenetic changes. Environmental changes, food can cause epigenetic changes, right? So
Yeah.
when somebody eats like a toddler their whole life and doesn't have their broccoli, they
Mhm.
have changes in their DNA that may be responsible for colon cancer developing,
Mhm.
right?
Okay.
So
Yeah.
those are things that are epigenetic outside of the genetics, but change the genetics.
Okay. That makes sense.
Nociceptor is easy. It's a receptor for pain. Those are
Mm.
those are the ones that transmit pain signals.
Okay.
So that one's easy.
Yes.
So the lobes of the brain. We did a lot of talk about this in some of the module introductions, right?
Mhm.
The ones that are important, well, you kind of want to have the broad overview of all of
Yeah.
them. Like prefrontal cortex is your executive function, right?
Yes.
It's also the frontal cortex itself, not the prefrontal. Frontal cortex is where we hold our inhibitions and our personality. So when
Mm-hmm.
you get somebody who's got a frontal lobe injury, you end up with bad Santa. So I took care of bad Santa some years ago in critical care. He was on a snow machine drinking,
Oh, no.
dump, and flew over the handlebars of his machine and hit the trailer head first. Ended up
Oh.
with two ventriculostomies, looked like my favorite Martian, which means I'm old because I know who my favorite Martian is. So that's personality. And I ran into him 9 months later. He'd been kicked out of a yet another nursing home. And I was with students on the floor doing clinicals. And he
Mhm.
comes out naked as a jaybird, just swinging it. You want some of the, nobody wants that. And you're scaring the nuns. And so I had to walk him back into the room while he's grabbing boobs or whatever else he could get his hands on.
Oh.
So frontal lobe.
Oh.
Hippocampus has a lot of different functions, including integrating memory. And the hippocampus is one of the places where we start to see some of the damage done by trauma.
Mm-hmm.
Okay. The amygdala is our fear center, but it's also our very strong emotion center. It does a lot with anger and fear.
Okay.
Wernicke's and Broca's are both verbal centers. And I always have to look them up because I always lose track of which one is which.
I remember Broca's, but I don't.
One of them's receptive and one of them is expressive.
I think the
So
Broca.
Wernicke is sensory, so it makes language make sense.
Hmm.
Broca's is actually producing the words in a way that's understandable. So Wernicke's is sensory, Broca's is verbal, the language center.
Hmm.
So both of them are about language. Wernicke's is reception,
Hmm.
Broca's is expression.
Okay.
Yeah, some of those I'll never be able to remember by rote. It's very sad.
So
Um,
somehow I remember one of them. So.
right. So 5-HT2A, 5-HT2C are serotonin receptors. They're the two most common receptors that we see used in medications. So I would review those.
Okay.
The CERT, NET, and DAT are presynaptic transporters. So these are the things that move dopamine, serotonin, norepinephrine from one synapse to another. They can also act as autoreceptors in some cases.
Okay.
Alpha 2A receptors, these are alpha receptors, and we see those are central receptors, and those are we use them a lot. Like clonidine is an alpha 2A
Yeah.
receptor agonist, clonidine. Guanfacine is another one. We use those for kids with focus issues with ADHD because it's not a good idea to start everybody on a stimulant right off the bat.
Yeah.
So the alpha 2A agonists are used to help with concentration, with alertness. So alpha 2, so when you look at alpha 1 is one we use a lot in med-surg. Alpha 1 antagonists are used to control blood pressure.
Hmm.
Okay. Alpha 2 agonists, the central receptors are different. So if I do an alpha 2 agonist in the brain, it's going to lower blood pressure, right? So
Hmm.
it does the same thing that an alpha 1 antagonist does. In the brain, agonism of alpha 2 is responsible for not only blood pressure control, but for keeping someone alert in the time. Because remember, if we're agonizing a sympathetic receptor, we're causing the fight or flight response. So when you
Hmm.
think about centrally, what do we need from the brain in the fight or flight response? We need the ability to concentrate and focus on what we're doing.
Yeah.
right? And so that's where alpha 2A agonism comes into play.
Okay. That makes sense.
Nicotinic receptors and muscarinic receptors are both parasympathetic, and they're a little more complicated.
Mm-hmm.
They have different types. And of course, nicotine is an agonist for the nicotinic receptors. And these are neuromuscular, but they're also involved in things like, we use these a lot for things like Parkinson's, muscular sclerosis, muscular dystrophy sometimes. So these are all about movement disorders. So we'll use cholinergic receptors like the nicotinic receptors or the muscarinic receptors to deal with side effects. That's
Mm.
mostly where we're going to see them used.
Okay.
So the muscarinic receptors have there several different types. You have some in the cortex, you have some in the GI tract, some in the salivary glands.
Mm-hmm.
And so we use the ones in the central and cerebral cortex when we're dealing with some of the side effects of different medications. And the nicotinic receptors can be, they're actually kind of funny because you have both postganglionic and you have preganglionic nicotinic receptors, and each of them works a little differently. So, the nicotinic receptor, the N1, is peripheral. So it's all about muscle movement in the periphery. The nicotinic 2 receptor is the one that's going to be found in the pre and post ganglionic locations. They also can be found in the sympathetic nervous system as a check on the fight or flight response. Does that make sense? So nicotinic receptors keep the fight or flight response from getting out of control
Mm-hmm.
through their parasympathetic function. So trying to think of some examples of drugs that we would use with nicotinic and muscarinic. So these are drugs we would use mostly for like Alzheimer's and Parkinson's disease.
Uh-huh.
And they're the cholinergic drugs are the ones that we use to hit nicotinic and muscarinic receptors. And cogentin is the only one I can come up with right off the top of my head.
Okay.
And so we use that. So remember I said like Parkinson's disease is an imbalance between dopamine and acetylcholine, where there's too much acetylcholine relative to dopamine. Okay.
Yes.
So dopamine levels are low. Acetylcholine's normal, but there's an imbalance.
Yes.
So we would use medications to bring that acetylcholine level down so that we restore the balance between dopamine and acetylcholine in movement disorders.
Mm-hmm.
And so when we have somebody who has some of the movement disorders, iatrogenic ones caused by the antipsychotics, we would use drugs like, for instance, cogentin to help to restore normal movement because of that side effect.
Okay.
Does that make sense?
Yeah, sort of. My brain is starting to.
No, it's all good. And we're recording, so you can come back and look at these again. So, acetylcholine is the main neurotransmitter for the parasympathetic nervous system. So it is responsible for neuromuscular, it's responsible for GI, and it is responsible for nicotinic and muscarinic receptor activation. Mu receptors they're very interesting because mu receptors are the ones that cause the euphoria when somebody takes opiates or heroin or what have you. But we're finding increasingly that mu receptors may have a role to play in things like other addictions and in depression. So there's a new drug that just came out. It's geez, what is it? It's a mix of olanzapine and samidorphan. And
Mhm.
it's a new drug for depression. What is the brand name of that? I can't remember off the top of my head. I'll think of it at 2 o'clock in the morning and email you. But samidorphan basically has an affinity for mu receptors that is 5 times greater than naltrexone.
Wow.
So it can help with addiction, but it
Mhm.
also can help when we work with the mu receptors and we do that intermittent blockade of mu receptors. What happens is we increase endorphins in the brain. So
Mhm.
when we do intermittent blockade of these receptors for our endogenous opiates, the brain says, whoa, wait a minute, I don't have enough feel good. And so the mu receptors, by doing that intermittent blockade, we cause the brain to produce more endorphins and upregulate mu receptors. So guess what happens? More endorphins, more feel good.
Yeah.
Also, the mu receptors, there's a few studies that have come out, and this is fascinating to me. We don't have any drugs yet. We have one that is in research right now. But we don't have any drugs right now on the market that affect the amygdala and the fear response for things like PTSD.
Mhm.
However, when we cause the endorphins to elevate and mu receptors to be upregulated, we also cause the fear response to be lessened. So there's some evidence for use of naltrexone in PTSD.
Oh, wow.
Yeah, naltrexone is actually pretty amazing. It can help with food cravings, alcohol cravings, obviously opiates, because that's what it was designed for. But it can also help with intrusive thoughts. So
Hmm.
I've had patients who have these suicidal thoughts that they just can't get rid of.
Yeah.
And we try all kinds of things, antidepressants, we do adjuncts to the antidepressants, nothing's working. I add naltrexone, they're gone.
Huh.
Yeah. I mean, it's not fast. It's not it's not flipping a switch, right? Same with someone with PTSD. It's several months later and they're like, huh, I don't feel this as intensely as I did.
Okay.
So those are mu receptors. Fascinating stuff.
Yeah.
So the inhibition and induction of the cytochrome P450 enzyme chains usually mess with people. How do
Mhm.
you feel about the inhibition and induction of the cytochrome P450 stuff? Do you feel comfortable with it, or does it still kind of throw you off?
Throws me off.
So, so let's talk about it. Let's see if I can't make it clearer. Ooh, I might have to go get my computer cable from upstairs.
No problem.
Actually, let me do that before I get lost. Right back.
Yep, no problem.
Made it back.
All right.
All right. Yes, computer, I know it's running low. We got it. So, cytochrome P450 is responsible for metabolizing drugs. It also breaks down hormones that are circulating so we don't get elevated levels.
Mhm.
It also mitigates toxic substances. But certain substances are substrates,
Yes.
certain substances are inhibitors, and certain substances are inducers. So let's talk about each of those.
Okay.
A substrate is any chemical that is metabolized by the cytochrome P450 system. For instance, nicotine from cigarette smoke is a substrate of cytochrome P450, but it is also an inducer. Okay.
Okay.
So let's talk about what it means to induce
Okay.
P450. So an inducer is something that speeds up the enzyme chain, makes it more effective, makes it work better. So if an inducer speeds up metabolism of the enzyme responsible for that drug, what happens to the level of that drug in the body?
It decreases.
Yes. So if I speed it up, if I induce the enzyme chain, anything that's a substrate will be reduced in the blood levels. For instance, cytochrome P450, the chain 2D6, is one of the metabolic chains responsible for the metabolism of aripiprazole.
Okay.
But it's an inhibitor. Aripiprazole is inhibited. 2D6 is inhibited. Okay. So if they're taking aripiprazole, which is a substrate of 2D6. Let's say they also take something that is an inducer.
Okay.
Okay. So if I've got an inducer of cytochrome P450 at 2D6, that means the levels of aripiprazole are going to drop. So
Yes.
let's see. Let me see. Let me find an example of an inducer. Oh, so let's say our patient who is on Abilify put on steroids.
Okay.
Prednisone, prednisolone, dexamethasone are potent inducers of cytochrome P450-2D6.
Okay.
So the levels of Abilify are going to drop.
Mm-hmm.
So something that inhibits 2D6, let's see if I can find an inhibitor. Here's a good one. So let's say that the patient who is taking Abilify gets hospitalized and develops delirium, and the doctor decides to give haloperidol.
Oh gosh. Okay.
That is a potent inhibitor at 2D6. So that will cause the Abilify levels to go way up.
Yeah.
Okay. So
Okay.
anything that inhibits that enzyme slows it down so that drug levels then keep going up, because
Yeah.
it's basically, do you ever watch I Love Lucy?
Yes.
There was a scene where she's trying to keep up with the chocolate machine.
Yep, I remember.
Okay. So basically the substrate are those little chocolate balls, right? And if I slow down the machine moving it through, I inhibit that machine, then the chocolate's going to pile up and Lucy has to eat more of them.
Yeah.
If I speed that machine up, then the chocolates are flying off the machine because the body is metabolizing it so quickly, there's not enough left for Lucy to eat.
Yeah.
Does that kind of help?
Yeah, that helps. That helps. That gives me a picture in my head.
Yeah, sometimes it's finding something weird to attach to that works, right?
Yeah.
Serotonin syndrome. Serotonin syndrome is a very rare potential adverse effect of medications that affect serotonin levels, and we don't have the corner on the market with that in sight. The drugs that are serotonergic, there are over-the-counter drugs. Let me see if I can find a list because it's a long one. Okay. So Trying to find, there's a list. The U.S. pharmacist knowledge. So the SSRIs, the SNRIs, the tricyclic antidepressants, and the MAOIs are obviously the most common. But dextromethorphan, which is cough medicine, also affects serotonin levels. St. John's worts, obviously, which is a mild MAOI, some antibiotics. So yeah, there's a whole bunch of them. Cocaine, fentanyl, lithium, methadone, methylene blue, mirtazapine, ondansetron, Zofran, right?
Yeah.
So the number of drugs that can contribute to serotonin syndrome are actually more than just the psychiatric meds that we usually think of.
Yeah.
But serotonin syndrome is an emergency because it causes extreme muscle stiffness. Now,
Mm-hmm.
when you think about extreme muscle stiffness, in order to do that, it requires the body to do a lot of work. And when the body does a lot of work, it creates heat. So serotonin syndrome becomes a problem because the muscles are so stiff that you end up with a high fever.
Mm-hmm.
You also end up with problems with respirations because it can affect things like the diaphragm and swallowing.
Mm-hmm.
And it is considered a medical emergency right now. Stop what you're doing, fix the serotonin syndrome. It
Okay.
is incredibly rare. Like I said, I've
Mm-hmm.
seen it once. My colleagues who also work in psych are like, you've seen it at all. They're surprised. It's that rare.
Okay.
Every patient who is put on a serotonergic drug, in spite of the fact that it's so rare, should have education about serotonin syndrome. And I actually use a handout from the Mayo Clinic that's brilliant for all of my patients. Because that one patient I had with serotonin syndrome, she'd
Uh-huh.
gotten a handout and read it, and she survived.
Oh, wow.
Yeah, yeah. So muscle stiffness, high fever, they start to become very confused. It's serotonin toxicity is what
Yeah.
serotonin syndrome is. So,
Okay.
um, any questions about that?
No, I think I understand that one pretty well.
Yeah, yeah. Treatment is typically things like we might use calcium channel blockers and benzos for the serotonin syndrome, and probably something to help with blood pressure control.
Mm-hmm.
And it takes a few days. I was actually really surprised. The patient that I had with it took probably about a week before she felt okay, normal again. It took that long for the muscle stiffness to recede because there's really no way for us to get rid of the serotonin
Mm-hmm.
except to wait it out. And so we do symptom management.
Okay. They do like cooling measures and stuff,
Mhm,
right?
mhm. Yep. Oh, absolutely. Yeah.
Yeah.
Yeah. Depending on the temperature. Yeah.
Yeah.
Symptoms of anxiety. Um, the symptoms of anxiety. So I usually will take patients through the GAD-7, Generalized Anxiety Disorder 7-question screening tool.
Mm-hmm.
So the questions on the GAD-7 are, um, so it's looking at the last 2 weeks. How often have you felt nervous, anxious, or on edge is first. Second, unable to control worrying about lots of different things beyond what would be considered helpful. Restlessness, inability to relax, um, irritability, easily irritated, and then feelings of impending doom. Those are all symptoms of anxiety.
Okay.
The stress response and the HPA axis. I would review this, but we can talk about it a little bit. Okay.
Okay.
Kind of run you through the feedback loops, so to speak. So the stress response, comes from the sympathetic nervous system,
Mm-hmm.
which is regulated by the brainstem. The brainstem communicates with the pituitary and the hypothalamus. Okay. So hypothalamus, pituitary, adrenal glands, those are the three pieces, the three parts that are responsible for what we see in a stress response. So let's say we're running from the big bear. That's a pretty big stressor, right?
Yeah.
So we recognize this stressor immediately. There's a signal sent to the brainstem that says we need to get the heck out of here. So the brainstem is going to give us either fight, flight, or freeze. Okay.
Yeah.
Most common is running, although freeze is pretty common as well. So the stress response signals the receptors, alpha receptors, beta receptors, both in the central nervous system and in the periphery. So the pituitary gland releases adrenal corticotropin hormone, which stimulates the adrenal gland to produce cortisol.
Mm-hmm.
Okay. The hypothalamus produces corticotropin releasing factor, which tells the pituitary to do that. So the hypothalamus produces a chemical that stimulates the pituitary to release a chemical that causes the adrenal gland to give us cortisol. Okay.
Okay.
What we're finding increasingly is that the pituitary and the hypothalamus, corticotropin releasing factor and adrenal corticotropin hormone, are playing a role in depression, especially in light of trauma.
Mm-hmm.
Okay. So the brainstem is responsible for stimulating the production of norepinephrine, which is responsible for more alertness in the brain and for an increased blood pressure in the periphery. And then the adrenal gland and the brain produce epinephrine, which gives us our increased heart rate, our increased respiratory rate, and bronchodilation.
Mm-hmm.
Okay. Take a look at the hypothalamus pituitary adrenal piece, most especially as it relates to trauma and as it relates to depression. Because with trauma over time, what happens is the body becomes less and less responsive to these chemicals because they're overwhelmed.
Okay.
So what we see is we may see the body producing less and less of the hypothalamus pituitary chemicals. So our cortisol levels are not responding to
Mm-hmm.
increased stress because basically it's kind of like what we see, for instance, in the brain. When there's too much of a neurotransmitter, the brain will turn off receptors to protect the brain, right?
Yeah. Yeah.
Same thing kind of happens with the hypothalamus pituitary adrenal axis. That overwhelming, prolonged stress response causes the chemical responses to be abnormal because the body is overwhelmed by it.
Okay.
Does that kind of make sense?
Yeah. Does it just is like desensitized or?
Yeah. In essence, that's exactly what happens. We end
Oh.
up desensitized so that our stress response is no longer normal
Mm-hmm.
under those circumstances. And corticotropin releasing factor is being looked at as a potential third generation antidepressant, looking at corticotropin releasing factor. So this is important to kind of review both for trauma
Mm-hmm.
and for depression.
Trauma and depression. Okay.
So when I say to you, who gets PTSD, who do you usually think about?
Veterans.
They are less than 1% of the cases of PTSD.
Yeah. Yeah. I guess what like
Because
abuse.
veterans are 1% of the population. So they're
Yeah.
less than 1% of the instances of PTSD.
Mm-hmm.
Um, PTSD is far more common, sexual abuse,
Yeah.
childhood abuse.
Yeah.
Um, so, so that's important to kind of remember.
Yes.
Review the drugs that are tyramine rich that people should avoid for MAOIs.
Okay. Tyramine rich
Yeah.
drugs.
So wine, most aged cheeses, any aged meat like sausages
Mm-hmm.
are on the list. So you want to kind of go through and review those just to be able to answer some of the most common ones.
Sure.
Okay. Now,
Okay.
smoking is an inducer of 1A2.
Mm-hmm.
Okay. So it speeds 1A2 up.
Mm-hmm.
Substrates of 1A2 include some of the older antipsychotics like olanzapine.
Okay.
So if I induce 1A2 by picking up a cigarette, what's going to happen to my olanzapine levels?
They increase.
Nope, they drop, right?
Increase.
We induce it. So if we
Yes.
induce it, it goes faster. The wheel turns faster and the chocolate's flying up the thing. So if I induce 1A2 by smoking, I'm going to
Yeah.
reduce levels of drugs like olanzapine. So if my patient who's been taking olanzapine starts smoking, what do I need to do with their levels of what do I need to do with their dose?
So decrease their dose.
Increase the dose
All
because
right.
it's being metabolized more quickly, right?
Yeah.
So if I induce it, it's going faster out of the system. So I need to increase the level.
Okay.
Okay. So maybe do it this way. Ooh, maybe this will work. So induce has a C in it. So does
Mhm.
increase.
Okay.
So if you induce metabolism, you got to increase the dose.
Okay.
Does that help?
Maybe.
Maybe.
I just need to lock it in my head like over and over with a flashcard or something.
Yeah. Grapefruit juice also inhibits certain substances. So grapefruit juice is usually a no-no for most people taking any
Yeah.
kind of medication.
Yeah.
So because it will lower their levels. It does it with like warfarin. It does it with what's the other one that's big? Amiodarone is increased or is reduced. The levels are reduced by grapefruit juice. There's a couple of them.
Okay.
There's a lot of them. So usually we just tell people just avoid it.
Mm-hmm.
You want to review the definitions of each of the schedules, right? Like Schedule 1 are considered no medical use. They're high abuse potential.
Uh-huh.
Examples in Schedule 1 include heroin and cocaine, the illicit street drugs. Marijuana is still a Schedule 1, uh,
Mm-hmm.
although probably that's not going to last.
Yeah.
Schedule 2 is where most of like Adderall and the stimulant drugs live. Schedule 3, your Z drugs, like your your sleep
Yeah.
drugs are
Yeah.
Schedule 3. Most other drugs are Schedule 4 or 5.
Okay.
Their lowest abuse. So Schedule 1 is highest potential for abuse. Schedule
Mm-hmm.
4 and 5 are the lowest.
Okay.
You want to look at the risk factors and signs and symptoms for Addison or for Alzheimer's and for Parkinson's disease.
Okay.
We talked about some of those with Parkinson's, and it's almost always a genetic risk.
Mm-hmm.
Alzheimer's, there's some genetics, but there's also some epigenetics involved. Age is a factor in Alzheimer's, although there is early onset is most commonly an older person disorder.
Yes.
There are 3 phases of addiction that you want to kind of review, right?
Yep.
The high that you get, the coming down and wanting the high, and seeking the drugs, that kind of business. You want to take a look at those.
Okay.
The neurochemical effects of alcohol and alcohol abuse. So I kind of want to cover this one a little bit. So nowadays you hear a lot in the literature about medication assisted treatment for addictions, right? Whether it be
Yeah.
heroin or benzos or cocaine or anything. Increasingly, it's about medication assisted treatment. The reason for that is the addiction itself, the overuse and abuse of these substances, whether it's alcohol or heroin or what have you, literally changes brain chemistry. So
Mm-hmm.
alcohol is a great example of this. So with alcohol, remember, alcohol is a central nervous system depressant, right?
Mm-hmm.
In the brain at any given time, the brain holds a balance between excitatory stimuli and inhibitory stimuli. The highest excitatory chemical is glutamate. The
Okay.
biggest inhibitory chemical is GABA, and there's a number of others that play in there, but those are the two main ones.
Mm-hmm.
So when somebody drinks alcohol chronically, daily, a lot of it, basically what happens is that central nervous system depressant
Mm-hmm.
increases the amount of inhibition that's occurring in the brain, right?
Okay.
GABA
Yeah.
is a central nervous system depressant, so is alcohol. So it has an additive effect. So now all of a sudden there's an imbalance between excitatory and inhibitory, and the brain hates it, right?
Mm-hmm.
So what happens is the brain says, well, I need to restore this balance. We got lots of alcohol coming in, so we can turn off GABA receptors.
Okay.
So the brain down regulates GABAergic receptors. So they're off, they're turned off.
Mm-hmm.
And then what happens? The patient comes into the hospital, 48 hours later, they're going through withdrawals.
Yeah.
So what happens with withdrawals? So remember, alcohol was maintaining that balance between excitatory and inhibitory,
Yeah.
and the alcohol's gone. So what's left? Excitatory.
Mm.
Insomnia, the tremors, the high blood pressure, high heart rate, the hallucinations, all of
Yeah.
those things are because there's an excess of glutamate and nothing to counter it.
Okay.
So we use benzos, right, for
Mm-hmm.
alcohol. And what
Yeah.
benzos do, right? So I don't have enough GABAergic function. What do benzos do? They mimic GABA. So
Mm-hmm.
we increase the amount of GABAergic function, right, which counters that excitability. But here's the deal. Benzos are not alcohol. So the
Yeah.
brain's like, wait, that chemical we were using is now gone. What
Mm-hmm.
do I do? That has to turn back on those GABAergic receptors. And if you've ever done a CWA protocol, and I did dozens upon dozens upon
Yeah.
dozens of them, you start off at these monster doses of Ativan or whatever it is that you're using, and you're giving it every hour or 2 hours.
Mm-hmm.
But over a few days, the dose and frequency decreases because
Yeah.
their symptoms decrease. Guess what's going on? While your dose is coming down, GABA receptors are being turned on.
Okay.
So that's why medication assisted treatment is so important, because we have to allow the brain the opportunity to reset the receptors that have been turned off and the neurochemicals that haven't been being used.
Mm-hmm.
Does that make sense?
Yes. Yeah.
Okay. So, neuroleptic malignant syndrome. Neuroleptic, we talked about serotonin syndrome. We
Mm-hmm.
talked about extrapyramidal. Let's talk about neuroleptic malignant syndrome. So,
Okay.
neuroleptic malignant syndrome is also emergency, and it is caused by antipsychotic medications most often.
Okay.
Now, it is also characterized by muscle rigidity,
Mm-hmm.
high fevers, changes in mental status, and dysautonomia. So, what that means is dysregulation of blood pressure control, heart rate control, respirations.
Mm.
Okay. So, with these, there's a lot of similarities between serotonin syndrome and neuroleptic malignant syndrome. Um, with with the serotonin syndrome, you're going to get hyperreflexia. You're going to get myoclonus. Do you remember how to test myoclonus?
I do not.
That's plucking way back to assessment class. So myoclonus you test when you have somebody sitting on the exam table
Yeah.
and you have them hang their legs loose and you turn their foot up real quick
Okay.
and they
Yeah.
get like a muscle contraction. That's myoclonus.
Okay.
Um, with neuroleptic malignant syndrome, you're going to get severe rigidity with hyporeflexia.
Okay.
Okay. Um, with serotonin syndrome, there's no lab findings. There's nothing.
Mm-hmm.
With neuroleptic malignant syndrome, we're going to find an elevated CK because they're starting to develop rhabdo. They're also going to have leukocytosis, elevated white blood cells.
Okay.
With serotonin syndrome, you see symptoms within 24 hours of starting or increasing therapy,
Mm-hmm.
resolved within a few days. Neuroleptic malignant syndrome takes 1 to 2 days to develop, or 1 to 2 weeks, excuse me, to develop, and takes about 2 weeks to resolve.
Okay.
Okay. And the big difference too is what drug were they on? Like if they have muscle rigidity and a fever and they're on an antipsychotic, it's almost certainly neuroleptic malignant. If they're not on a dopaminergic agent, there's something serotonergic in their medications, then it's serotonin syndrome. Is that helpful?
Yeah, that makes sense to differentiate.
Okay. And then, I listed a couple specific medications in the drug review table.
Mm-hmm.
So you just want to look at those specific drugs, but
Okay.
also be ready to answer questions about the drug classes, right? SSRIs, tricyclics, mood stabilizers, and what have you.
Okay.
Okay.
So just in those categories, like be
Yeah.
able to answer. Yeah.
Yeah.
Okay.
And you want to give yourself, you don't want to try and remember every single drug. It's
Yeah.
impossible. But if you understand how a given drug class works overall, you
Uh-huh.
can then start to learn some of the differences, right? Like with the
Yeah.
SSRIs, they're all very similar, but Paxil has a little bit of something that tends to work better on somebody who has anger issues. Like I tell people all the time, Paxil is the best one for cranky old men, right? But it
Yeah.
not so much for someone who's got just general anxiety or depression. So
Mm-hmm.
it's for somebody who's a little more irritable, right?
Okay.
So, kind of getting that down, the basics of the drug class, you can start then to remember things that are different about the other drugs. Like
Mm-hmm.
when you look at the stimulant drugs like the amphetamines and the other stimulants,
Mm-hmm.
amphetamines are more potent and last longer than like Ritalin, methylphenidate, and stimulants like that.
Yeah.
But if you understand how the stimulants work overall, you got most of the picture down.
Okay.
That kind of makes sense. So
Yeah.
focus on drug classes rather than on individual drugs.
I can do that. And then later on you can just plug in the individual.
Little by little, as you get used to these medications, as you're using them more, as you're prescribing them more, these things start to stick
Yeah.
probably quicker than you think, right?
Yeah.
And you're going to learn the most common drugs first. And guess what's on the certification exam?
What?
The most common drugs.
Yeah.
Yeah. It's kind of like with NCLEX. They're not going to ask about the least common disorder ever
Yeah.
because who can answer that?
Yeah.
They're going to ask about the most common stuff, the textbook picture of the most common stuff, and they're going
Mm-hmm.
to ask about the most common drugs that we use,
Yeah.
right?
Yeah.
And so, kind of stick with the drug classes and common exemplars. And
Okay.
when you're thinking about side effects and interactions, you're thinking about the drug class overall. And then later on, as you're getting into the weeds with specific drugs, you'll start to recognize things that are a little different one from another.
Mm-hmm. Yeah, that makes sense.
Because trying to remember every single drug that we're going through is not only impossible, that would be exhausting.
Yeah.
You
It
know?
would be.
And
Yeah.
and here's the deal: if you aren't looking stuff up all the time, it's a mess. You want to, so you're going to be looking this stuff up over and over again in clinicals, and you're going to look them up. I keep Stahl's prescriber's guide
Mm-hmm.
on my computer. and
Okay.
I use it every single day, whether it be, to when I'm switching antipsychotics from one to another. Stalls provides some guidance about how to do that. If the patient comes to me and they're saying, I've got this going on and I don't know, I think it might be the drug. I look at Stalls to see if that's something that he even lists. And then I
Hmm.
search the internet to look further to see if it's something uncommon. So all of this stuff is going to start to stick over time.
Okay.
Yeah.
I hope so.
It really, you'll be surprised how quick some of this stuff starts oh, I remember this. I remember this stuff.
Yeah. Yeah.
So it's going to be good. Remember that, tricyclics, one of the big side effects is cardiac. They're
Hmm.
actually one of the worst ones to give to somebody who's suicidal, because if they overdose on those, it's going to work,
Okay.
right?
Yeah.
MAOIs, the big thing is the tyramine foods, right?
Yes.
And any other serotonergic drug an MAOI plus a recent SSRI, if you don't give enough of a washout, will cause serotonin syndrome, period, end of story.
Weeks, right?
An MAOI plus any serotonergic drug recently, if you don't give enough of a washout of like an SSRI or an SNRI before you start an MAOI, they will
Yeah.
develop serotonin syndrome, guaranteed.
Yeah. Isn't it like a 2-week window though, right?
You
Before
want to
you.
look at the half-life and give it at least 5 half-lives. I
Oh,
usually go for a little more.
okay.
Yeah,
Okay.
yeah. Antipsychotics, remember the cardiometabolic monitoring is huge. With lithium, remembering that you want to monitor lithium levels. You want to start with a week after starting the dose, and then every 3 to 6 months after, depending on how stable they've been. You also want to watch kidney function and thyroid function with
Yeah.
lithium.
Uh-huh.
Amphetamines, any of the stimulants with kids, you have to watch weight. And if they're losing weight, they don't get to keep the stimulants.
Okay.
Yeah, that's a big one for kids. Um, yeah, that's a good start.
Okay.
Lamotrigine, one of the mood stabilizers. Several of the mood stabilizers like carbamazepine, oxcarbazepine, lamotrigine. Most of them are anticonvulsants.
Mm-hmm.
Some of them you have to monitor levels, like Depakote. You have to monitor levels
Yeah.
for that. And there's a risk with any of those for a Stevens-Johnson like skin reaction. So part of
Okay.
your education that you're giving to the patients with the mood stabilizers is to call for any rash. And then you'll learn how to differentiate a benign, this is just an allergy reaction
Yeah.
versus Johnson.
Okay.
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 All right. Did you find this helpful? I hope.
Yes, very. Thank you so much for your time. I really appreciate it.
That's what I'm here for. It's what I'm here for. I haven't done as many of the recordings as I wanted to because I had a lot of things come up this semester.
Yeah.
So I'm glad to be able to do this tonight. I wanted to do this more.
Yeah, thank you so much. It is really helpful just to kind of hear it and
Hmm.
helps it sink in a little bit.
Yeah, it's kind of hard because they